Good morning, everybody. Thank you for joining us in this webinar. And thank you very much for the invitation to participate. Thank you, Dan, George, Aaron, Richard, and the rest of the team. And also thanks for everybody organizing it and being patient enough for me to do my recording. I wasn't fast, I can tell. This is my disclosure slide. I have no financial interest in PRP or stem cells or any regenerative medicine products. I'm the co-founder of Pain School International. I'm on the WIP Education Board, and I teach for a variety of societies like WIP, ASRA, ACIP, Singular, possibly. I collected the data on our regenerative medicine experience. We started in our Budapest practice prolotherapy in 2006. I actually learned it from Dr. Andrea Trescott, my lovely mentor, and I will always be grateful for this and many other things to her. And even in the same year, in 2006, we purchased our first PRP machine because we thought it has to be even better. Now you're not injecting sugar water, but injecting the platelets themselves. And over time, we performed over 1,000 cervical and at least 6,000 lumbar spine regenerative treatments. About 2,000 of them were with PRP, some stem cells, and the majority is with prolotherapy. So here is the outline of this talk. At the beginning, we're going to talk about the diagnostic approach to the spine. That might be the shorter, but the most important part of this talk. And then we can discuss how to inject and what's the evidence. If you look at PubMed and you put PRP, you find 17,000. That's a lot. And if you put PRP review, you find over 2,000. But let's put PRP spine, and you find over 1,000 results still. So the number of publications are going up every year. So this is the one conclusion we can make. This is a very, very hot topic. I think one of the most interesting area of pain management. And it seems, at least to me, it seems it answers a lot of questions that we failed to answer with standard therapies. But of course, much of it remains to be still proven. So what's the concept of regenerative medicine? Of course, it's the inflammatory cascade that we create that leads to cell proliferation and matrix remodeling and possibly reinforcing the damaged tissue. And this slide shows you how the various regenerative medicine approaches feed into this inflammatory cascade. I would start at the very back here at the tissue healing. That's what we want. And we know that inflammatory cascade leads to tissue healing. Now you can feed into this process at the level of PRP. You put PRP, it's immediately the platelets themselves, they activate. You're at the inflammatory cascade. But you can also connect to this algorithm by prolotherapy, where with the sugar water, the hyperosmolar solution, you create a cell injury, a lipid leakage, and when the membrane is exposed, then the platelets activate. And of course, the stem cells are also important. They don't necessarily turn into cartilage if you put it at the cartilage or tendon. 99% of the cells actually are not there a week later after injection. But what they do, they orchestrate the inflammatory cascade, the healing process. They are modulated cells. So what's the diagnostic approach for spine? I'm going to show you cervical spine, but it applies for the rest of the spine, and actually it also applies, I believe, for the rest of the body. If you look at these two images, they're almost identical. They show cervical spine. However, this one has the ligaments, and you see how much, it's a cartoon of course, but go in the dissection room and you'll see it's very similar. There's a lot of tissue here that's responsible for creating the stability. So this is limiting your neck flexion. It is actually limiting your neck rotation. This has a very important biomechanical function. And this is how your neck would look without the ligaments. The muscles would not be able to hold your head up on your neck. Look at this drawing here. If you think of a whiplash injury, which is easy to imagine, it's trauma. A whiplash will lead to the stretching of the of the interspinous and supraspinous ligaments. And if the spinous processes separate from each other, then you can understand there is a stress on the facet joints, there is a forward pressure on the discs, and the disc will bulge out posteriorly. It can put pressure on the posterior longitudinal ligament, which is very painful, and create a very complex cervical symptomatology. And depending on what's leading the picture, it can be a facet problem or a disc problem. One thing that you always see on these MRI descriptions is there's a loss of lumbar lordosis or cervical lordosis or a loss of lumbar lordosis. And of course, if it gets bad enough, then it can create a radicular pain and radiculopathy. This is a slide that I used to show to my patient, but I no longer do. I think it's too traumatizing. But this explains this concept of the spinous processes separating and the disc bulging out and putting pressure on the exiting nerve root. So in summary, when a patient comes to me, this is how I think of them to understand their pathophysiology. We can think of extraspinal problems. That includes the ligaments, the facet joints, and of course the muscle attachments, the tendons. And you can also think of disc, as we just discussed. If the disc is compromised, then it can create discogenic pain. The disc painful itself, but if it leaks with an annulus rupture, then the nerves will be irritated, and of course it can cause a physical compression on the nerve. Now let's get to the intraspinal pathologies. Of course, we have to put nerve mechanical compression here and nerve chemical irritation. And the treatment goes accordingly. So for extraspinal, I do PRP or prolotherapy to reinforce the posterior elements, reinforce the structure. For intraspinal, there are some studies showing benefit with regenerative medicine and PRP. And in my practice, it's mostly still the transforaminals or epidural lysis, and this is the very, very little area of pain management where I still use steroids. And then for the discs, you can put PRP or stem cells in the disc. You don't want to forget about the other treatment approaches or the radiofrequency approaches, but they get usually very popular and then they fade away because they are actually not that great. So here is the first conclusion of this talk. When you do regenerative medicine, I suggest we always think in functional units. Don't just think of a disc. Don't just think of a knee meniscus, because the reason the meniscus is in trouble because the collateral ligaments and some more are already in trouble. Going back to spine, these are your targets: discs, facets, ligaments, and tendons, and of course the epidural is coming up. I will review them structure by structure, even though you think functional units and you inject functional units. But the literature is still focusing on individual parts most of the time. So for lumbar facet problems, I believe these targets, iliolumbar ligaments, facets, supraspinous ligaments, SI joint, posterior capsule, and the thoracolumbar fascia are all part of the problem. But thinking facets, let's look at the evidence. And before we get to how good or bad it is, what I want to point out that with regenerative medicine, there are no serious complications. The complications happen from the actual needle placement, not the regenerative medicine itself. And I will show you the exceptions as well. But these are the studies available for lumbar facet joint for PRP. The one that's, I would say, the most serious is a prospective randomized controlled trial by Wu. It's a level 1 evidence. He looked at 46 patients and functional outcomes. And he found significant sustained improvement with the PRP at 6 months, not with the steroids. This is important because a lot of studies are looking at 1 or 3 month benefits, but the patients are chronic pain patients. They will be in pain for years and years and years, so we need to look a bit ahead to see if we have options to treat them that last beyond a month or 2 or 3. Here's another prospective series by Wu, and there is the Kirchner study that had excellent, absolutely excellent outcomes. Many actually don't believe it. I do. He looked at 86 patients, and what he did, it's not on this slide, he did not only inject the facets, but he injected transforaminally and intradiscally. So again, he was thinking in a functional unit a bit more than the rest of the studies. So he's an outlier in that. He is also a prolotherapist, so that's his background. So looking at these studies, positive, 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 and no adverse events. That's pretty good. I think we need to review prolotherapy as well. We have one double-blind randomized controlled trial looking at 74 patients. What he found comparing prolo to saline, that both groups improved in pain and both groups maintained their benefits actually over a year. It's not in this slide again, but that tells us the placebo was not a true placebo. So as long as you create inflammation, you trigger the inflammatory cascade, you will get benefit. And here is the Hooper study, and again, Kirchner did a prolotherapy study as well with excellent outcomes, following the patients for some of them for 2 years. Methodologically, not very good studies, but positive, and no adverse events. Now, how do you find your facet patients? It's the same as we learned with standard pain medicine. It's the ones who has pain on the extension and rotation. You will find the paravertebral spasm, and even more, you understand the mechanism of injury. I lifted something heavy and twisted, then it comes. Or patients who are rear-ended, they can be typical facet pain patients. Now, how do we inject? Honestly, the technique is no different than anything else we learn ultrasound-guided lumbar spine injection technique. But this is my injection for the supraspinous ligaments. As we discussed in the lumbar spine, they're also very important to maintain structure. And I just palpate the spinous process between my fingers and inject on top of the spinous process on bone. Stop. The only thing can go south here if you go too deep and create a postspinal headache. So that we need to avoid. But it's usually an easy target to palpate, better than any image guidance. And you inject the facet and the transverse processes as well. This is the needle orientation and the probe orientation, and here you can see the needle advancing to the transverse process. And then the needle gets withdrawn and targets the facet joint. You don't need to put extra effort to get into the actual joint space. As long as you get to the capsule, it will be enough. And then I withdraw the needle and I will target the lamina as well. Here, what you want to see is if you don't see the dura here and there, then you're hitting spinous process, not the interspinous ligament, which keeps it nice and safe again. Of course, you can also inject fluoroscopy guided. Again, the injection method, landmark fluoroscopy, ultrasound does not matter. As long as you understand the anatomy, you understand the functional unit, you will be successful. So this is a facet injection. If you place multiple needles, it speeds it up. You place the 3 needles, look at the X-ray, adjust the 3 needles, and look at the X-ray. It's less radiation and faster procedural performance. Here you can see the transverse processes injected. This is where the interiliolumbar ligament connects to the ilium. Now let's look at the lumbar spine and the disc for now. Let's look at first at what does the literature say about disc regenerative medicine. So here you can see a variety of studies. In this one by Karl Lutz and his team is possibly the best one. It's a prospective, double-blind, randomized controlled trial with 47 patients. And the follow-up is nice and long. He compared PRP versus the sham group was a little more contrast. And what he found at 8 weeks, that the PRP group did way better, and then people could cross over. He actually published 3 papers of this with longer term follow-up. But the PRP group led to a sustained significant benefit compared to the other group. The rest of the trials are lesser in quality and looking at 20 and 14 patients. Not all of them eventually showed benefit, and all of them had a reasonable follow-up period. So these green ticks mean that PRP groups were better or were showing benefits. And again, I wanted to say there is no adverse events. However, there is this study that showed discitis infection. This is very unfortunate and it's very difficult to treat. It needs a long term of antibiotics. It's a procedural complication. I'm not quite sure it's a PRP complication. It's a needle placement. It's a lack of pre-op antibiotics, possibly. This is animal data. Just I find it interesting that in animals we can already see that if you put regenerative medicine, PRP or stem cell in the disc, it actually shows an improved MRI over time. And this is another very interesting paper that's from 2018. It's also an animal model, but what it found that if you put leukocyte-rich PRP in your disc, that promotes degeneration. However, if you put leukocyte-poor, that helps the disc to recover. Let's look at the lumbar spine and the epidural injections and the evidence. We have a few studies. One of them is a randomized controlled trial with 84 patients, and it seemed similar in benefits to the triamcinolone. However, at 26 weeks, half a year, the PRP group was better. Not in function, but pain-wise. There is also positive response in this prospective registry by Sentinel, 470 patients, big number. However, 26% of the patients did not show benefits. I think when we do disc PRP, much of the time, as we withdraw a needle, by the way, we do put a little bit of PRP to the foramen as well. And here is the Kirchner study that we talked about previously. He injected 3 things, transforaminal, intradiscal, and facet. Very good outcome. I think he's right. We're going to talk about sacroiliac joint. I think it's really part of the spine. The literature says significant improvement in a prospective randomized controlled trial. Very low number of patients, 40. But even at 3 months, the PRP group was doing better than the steroid group. That's exactly what we observed. And there's a case series, even lower number. Nevertheless, good outcome. And no adverse event. I don't think we can miss prolotherapy from Sacroiliac Regenerative Medicine Review. Here are two studies. One is level 1 in RCT. It found no difference short-term between steroids and prolotherapy. However, at 15 months, which is over a year, the prolo group did much better than the steroid group. And again, no adverse events. How do we find our SI patients? Of course, there are obvious falls where the mechanism of injury shows shearing injury and you expect the SI. But the patient will point to the area on one side. They can have referred pain down the leg, and you can do the diagnostic tests. They still don't make it sure that it's an SI problem. So you can do a diagnostic injection that confirms the diagnosis. Here are your SI provocative tests: the distraction, the compression, the thigh thrust, the Faber, and the Gainsland maneuver. And these are the ligaments. I'd like you to remember that the SI joint is such an important, such a strong joint. It essentially holds the upper body, really. So you have a variety of ligaments that are crucial: the iliolumbar, the SI capsule and ligaments that hold the ilium and the sacrum together. And look at the supraspinous ligament, how big, and connects all the way along to the coccyx. And here you have sacrotuberous, important structures in biomechanical function. So again, you're treating a functional unit. You're going to inject supraspinous ligament, right? You're going to inject facets, iliolumbar, the posterior capsule for the SI, and the thoracolumbar fascia as well. This is my way of injecting the sacrum. This is the view I get at first. I center my curvilinear probe to the sacrum, and of course you can see the S1 foramen, the sacrum, spinous process, and the ilium. Then you slide laterally with your ultrasound probe. So here you have ilium and sacrum and spinous process. And this is the injection technique. Here the needle entry is here in the center. So you slide laterally until you identify the iliac crest. You see the sacrum, and the needle is coming down to the sacral surface. Then I withdraw and inject the kind of the undersurface of the ilium. Then this was position 2 in the ultrasound. Then I rotate my probe to position 3, and I do the exact same thing. This allows the PRP to get to all the relevant ligaments, and then I rotate to position 4 to get to the lower ligament. So here we are at the cervical spine area, which is by far my favorite. I will try not to get lost in the details. Let's review the literature. Very easy because there is so little. There's not much available, let's put it this way. But this is an interesting study by Centeno, because what he did, he actually studied the movement of the vertebra. Here you can see he's looking at the translation. How much does the vertebra slip forward when your neck is in flexion? Or does the angle change too much? That's how he identified cervical instability and injected patients with prolotherapy. This is a healthy spine. On the left, of course, you see its nice harmonious line. And this is a problem spine with instability where there is a anterior slippage of C3 and C4, or a posterior slippage. And here you see a flexion extension movie, very interesting. You see the C4 slipping forward on C5 much more, and C3 also moving more on C4 than the others. So those two segments might be a problem for this patient. If you look at patients with car accident to identify ligamentous injury, the C-spine X-ray, just the normal, is 80% sensitive, whereas if you send them for a flexion extension view, it's 99%. So what Centeno did, he collected patients who had more than 2.7 millimeter translation, forward or backward slippage, and he applied prolotherapy. And what we found that in the C2-3 segment and C5-6 segment, which is typically the worst in car accident, he actually could decrease the translation at both. And the VAS scores decreased for all patients. Very low number of patients. I think it's more like a pilot study, but also very interesting. What's the technique? Of course, you think functional units again, and you inject supraspinous ligaments, facets, superficial cervical muscle, deep cervical muscles, laminae as well. This is the patient position. Again, look, she is comfortable. Her neck is in flexion, which is easy to inject. The patient can breathe. So that's the perfect positioning. For IV, for cervical spine, I place an IV always. And because I can do sedation in my clinic, I actually make them NPO. But that's not necessary. You can do in local anesthesia. It just takes much longer. So here is the technique for injecting the supraspinous ligaments. Again, I'm bracketing the target, the spinous process between my finger, and then the needle goes on bone. This is prolotherapy. If you want to inject the cervical facets, which you want if you're doing cervical spine, then the technique that I developed for myself is actually based on Finlayson's publication. He is injecting from posterior to anterior onto the articular pillar. Now it's the same technique. If you slide a little bit caudad or a little bit cephalad, you actually get to the facet capsule. Here you can see cervical facet and lamina PRP injection on a migraine patient who's actually responding quite well to it. Here you can see this is posterior and the needle is approaching towards the C1 lamina articular pillar. The way you can tell that this is C1 is that I pre-scanned, which I'm not showing it to you to save time, but this has a round lamina and no spinous process. The needle can only go if it is actually visible, clearly visible on the ultrasound. No needle, no go. You can see I'm redirecting my needle to the lower part, to the lamina level. And again, no needle, no go. I'm injecting on bone. And mind you, the spinal cord is actually here. So if you don't see, you don't go. This is already the C2 level. The way you can tell, again, that here is the articular pillar and the big spinous process, big lamina and spinous process. You can see the needle touching down on the articular pillar. Then I redirect on the lamina and then withdraw. Then you slide to C3, and this is the level where it actually starts being beautiful. You get the typical happy view of a big articular pillar and nice, sharply visible lamina. This is, I would say, a pretty advanced procedure, so I recommend everybody to be very comfortable with hip, knee, and elbow, shoulder, and lumbar spine before you get here. Of course, you can inject X-ray guided. This is the atlanto-occipital injection, very important in whiplash injured patient. Similarly, the atlanto-axial joint injection. So what are the contraindications? I would say there aren't many. Infection, lack of consent, of course, lack of procedural skills for the procedure. And relative contraindications are the anti-inflammatory medications, NSAIDs, steroids, and patient's poor lifestyle. Nobody will do better with any interventions if they are obese or smoke and don't do any physical activity. This is what I tell the patient. I tell them that they come in with, let's say, pain of 5 or 6. They get a bit worse from the treatment and then improve over time. Always a bit worse with the treatment, but the trajectory is towards good. This is similar with prolotherapy, but they need more treatment. So this is my conclusion slide. Beautiful regenerative medicine treats the cause of the pain. It fixes the biomechanical imbalance. You can use for accident, for wear and tear, and it restores the function. Studies are available, but they are not enough. We need to do more. Finally, this is a patient of mine who had about 20-year history of lumbar pain. She could not sleep through the night. She had to go in a child pose after about 2 hours of sleep, and you can't sleep like that. And she underwent L3-4, 4-5, and S1 facet injections bilaterally, twice with prolotherapy, twice with PRP. And she's been pretty close to symptom-free ever since. And she sleeps through the night, no problem. Thank you very much for your attention. I appreciate your time in the weekend. And if you have any questions, you can email me at stogicza@gmail.com. It's my last name, @gmail.com. Bye-bye.